All right. I think we have many familiar partners in the room and in Zoom joining us, but I'm eager to hear who in the room have heard about Blooming Health before. So I'm not repeating myself, but I'm also curious who don't know what we do, right? So thank you. I'm Kavitha Gnanasambandan, as I mentioned before, co-founder and chief commercial officer at Blooming Health. We are a technology company. I think I've mentioned this before, and I'm underscoring it mainly to highlight that we are an enabler of care, and we look at technology as a tool in the toolbox to drive access to care. And we initially, again, started this company with a lot of experience as a caregivers. And I say we, me, Nima, Naman, but we are a team of caregivers here that's lifting us through this. And Marina here tells our story really well that we are continuously learning and improving our solution based on our own experiences in our lives, but also by partnering with partners on the ground, specifically with the mission of connecting medical and non medical care. I think there was a really good question from Heather earlier on how do we make sure that pre Parkland Health people actually get there? What happens outside the hospital walls? So that's why we started building Blooming Health in the community with community organizations to remove barriers to care and continue to deploy AI based agentic solutions to remove those barriers, whether they be non medical, social, or any economic barriers as well. So, our vision is to build this AI enabled platform to connect non medical and medical care to drive outcomes for individuals, regardless of who they are, regardless of their circumstances. Next slide, please. So we don't want to build technology in isolation in an ivory tower, right? That's why we are here. One of the reasons you might be thinking, why are you in Dallas? We work with a lot of partners in Dallas, but also we want to go on the ground, learn the lifestyle, learn the actual disparities on the ground to design the experience for the members, for the staff, and for the partners who are going to work together. So we've built our solution from the ground in 26 states. We partner with around 1,500 community based organizations that deliver services from birth to death, as I described earlier. And we are touching 6.5 million Medicare and Medicaid members. And what our technology does, you're going to hear soon from Phil. But as I mentioned, our goal is to enable care, drive connections, and we've done this through 19 million touch points over the last 5 years across these states, across these members. And that's why I want to acknowledge some of the partners we've listed here from WellMed to Dallas County Social Services, Tarrant County United Way, WeBridge San Antonio. All of these partners have helped us truly understand what it is to serve members on the ground in Dallas, in Texas, and what type of barriers can our platform help address and remove so that we can meet people where they are and connect them to these services and remove the barriers to care. So at this point, I'm going to hand over to Phil.
Thanks, Kavitha. Can everybody hear me okay? I'm a loud talker too, so I'll try to keep it down. But just as an introduction, my name's Phil Harker. I'm the head of growth here at Blooming Health. And my job today and my objective is that you understand exactly what we do when you leave here. And why we're bringing everybody together. But as a side note, I loved when the former mayor Hancock said he's from Texas. Because I lived in Texas for only a couple of years, so I'm not a Texan. So I'm not going to stop my shoes. I don't have boots on. I just have just normal shoes. But I used to say, I've told everybody, well, how was it living in Texas when they asked me? And I would go, Texas isn't a state of the union. It's a state of mind out here. And I love it because everyone's so proud to be from this area. I was only here 2 years, but by the end, I had boots. I had my boots that I wore. We didn't talk about guns, but I love this area and love being here with you all today. I grew up in Las Vegas, so I'm very comfortable with a microphone up on a stage. I may sing a song in just a minute here. But the first thing I want to talk about is to repeat some of what Kavitha said. Our technology is built to try to be, and we are being, the glue between a number of organizations that we still consider health, that are delivering health, but they may be medical health or they may be non-medical drivers of health. Because when you look at putting the center of what we do, that's what we try to do here at Blooming Health, their medical care, and we're bringing health systems to bear here, health systems here with us on Zoom and in the room, and health plans as well. So I'm saying this at the I don't think it's going to say something that people don't know, but health care or the medical care is secondary to those non-medical drivers of health. They will prioritize that over their clinical care most days of the week. So until we learn how to integrate the two together, we won't achieve the access to care that we so desperately need in our communities. And so that's really what we're trying to do with the agentic AI technology solution that we have, is to try to put the member at the center, then look at their care holistically and look at what barriers are preventing them from achieving the access to care that they need. Now, I'm going to say something that I believe, because I've been doing this for a number of years. I've been in the healthcare industry for over 30 years. The last 12 to 15 has been around serving underserved communities and truly understanding how they think and what they do. And I think the number one barrier to care in the United States is health literacy, is just knowing what programs are available to them, what they can do. How do I get to, should I be going to a Instacare, an urgent care, to an emergency room? Do I just call my doctor instead of an appointment? The average person doesn't understand that. And I would venture to say, even all of us in this room, I loved when the county commissioner said, we're all looking at what the federal government's doing, looking at what the state government's doing. And I know everybody in this room is looking at that because of their jobs. The average consumer of healthcare, they're not looking at it. They're not looking at what's being done. They have no idea. And so if things are changing, they have zero idea of what's happening. So part of what we want to do is make people aware of those things, but give them the information they need at the time they need the information. There's so much data on the web. All those programs are on the internet. But these people aren't looking up those things until they actually need that information. And so that's part of what we're trying to do, again, using a very conversational AI technology, partnering with a number of people to bring those individuals, those consumers of healthcare in our communities, the things they need at the time they need them. So that is, and then ultimately, we believe that it improves patient outcomes. It does. We've proven that it does. And equity, because we're seeing that we're able to do it. See, with agentic solutions, we're able to communicate with people in 57 languages, and not just the languages, but various dialects of the languages as well. So we're trying to build trust with individuals and then help them with what they want help with, not just what we want to impose upon them as individuals. And that's what we're going to do. And we're going to show you a little bit, but the next slide talks about kind of how we do it. So we develop what's called care enablement workflows. And what those are is they are workflows that we put an individual in to guide them through an experience to achieve an ultimate outcome. All of our care enablement flows have ultimate outcomes, and they vary from primary care type of workflows to chronic illness, to maternal health, women's health, a number of different workflows that we have. And how we do it, we identify the need that's in the market. We develop a workflow, manual, draw out a workflow that needs to happen, And these aren't just a one-touch workflow. These are multi-touch workflows. It could be annual, 12-month, 18-month workflows when it comes to maternal health, for instance. And then we look at our library of agents. Now, we develop agents in a way that they are very specific to tasks. They become experts at doing things. An agent that collects information. We call it the survey agent, but we don't do a survey. We just collect information from individuals. We find a very natural way of doing that. But there's also a welcome agent. There's an appointment scheduling agent. There's all these different agents that that are in our bank in our library of agents, and then we bring them together to create a team of agents that are going to guide people through these workflows. And it's a very coordinated intervention. So it's not autonomous technology. Obviously, you're all here hopefully on Zoom because you know it's not autonomous. So what we do is taking people through workflows. We do transfers to different lines to get a person engaged. There's certain things that will never, ever be done with just technology, right? So technology needs to be an enabler to connect people with the people they need to connect with. Oh, it just got louder all of a sudden. Now I can hear myself better. I love hearing myself talk through a microphone like this. But the ultimate, with the coordinated interventions, they'll work together achieving the ultimate outcome, which may be a very clinical outcome, because that's what ultimately we want them to do. We want them to access care, become healthier people, and remove any barrier in the middle that's causing them to not access that care. And that's what our care enablement workflows are focused on, is focused on those outcomes. So instead of talking a lot about them, and hold on the next slide, don't turn yet, but I'm going to kind of intro what we're going to see. These are snippets of demos. You're going to hear audio files of an agent talking with a person on the phone. This first one is around Medicaid renewal. So that's becoming, has been an issue, continues to be an issue. And that may not be a clinical outcome, but it's definitely an outcome that needs to happen if we want to try to get as many people continuing with the program with Medicaid that are inside of it. It became a large issue just a few years ago when at the end of the pandemic and the unwinding of the pandemic, there was a lot of angst around getting a hold of these members to get them to apply and meet the requirements of Medicaid, to make sure they have the requirements of Medicaid. I did some research nationally, and there was a huge reduction in Medicare. It was like Medicaid, apologize. Medicaid, 18 to 20 million people nationally lost coverage to Medicaid during that unwinding. And 70% was not because they weren't eligible, it was what they call procedural. They just didn't apply, right? Because they didn't know what to do. They didn't know how to do it. They didn't know the new requirements that they needed to meet and how to fill it out and get it done. Even though paper was mailed to every single home, you know, they didn't know, they didn't go through it. In a lot of states, there was a lot of outreach that was happening, a lot of things that were occurring. In the state of Texas, there are currently 4 million Medicaid, I'm rounding the number, it's probably plus or minus, but 4 million Medicaid recipients in the state of Texas. We're about to go through another one of those changes where there's a lot of new requirements that are now being imposed on individuals. And again, it's going to be another, I can't call it an unwinding, it's a new winding, right? We're winding up new requirements for Medicaid recipients around work requirements, volunteerism, a lot of things like that exist. And so it's going to start, when it comes into effect, we're going to see if we don't figure out how to accomplish that, there may be another reduction, a significant reduction. And we all know what happens with significant reductions. It puts a huge focus on safety net hospitals and all the other hospitals, on care in general, because there's a lot of uninsureds and in the system. So that example. So this first example is just a call to an individual to try to help them with the process. So let's go ahead and listen to this real quick.
My name is Alex, and I'm calling to help you with your Medicaid and SNAP renewal. I'm calling to make the process easier for you. Can you confirm your full name, date of birth?
My name is John Smith. My phone number is...
Thank you, John. Now I need to gather some information about your household. Could you tell me who currently lives with you at your address?
I live with my wife. Her name is Susan.
Now, let's talk about income. Do you or Susan have any income from any sources?
We have some income from our pension.
Okay, great. Can you tell me how much you receive from your pension each month?
I receive $3,000 a month from my pension.
Okay, John, I think I have all the information I need. Let me just quickly review everything to make sure I have it correct. You are John Smith. You live with your wife. We need a copy of your pension award letter from the State of Ohio Pension Fund.
Please send me the text message link.
I will send you a secure link via text message where you can upload photos of your pension award letter. I am now generating your pre-filled renewal forms based on the information you provided. You will receive the forms via text message. Submit them according to your state's process. This usually means mailing them back in the envelope provided or submitting them online if that option is available in Ohio.
It went through what I explained it would go through. So it's the ability now to compile that information, and we would actually send the information over to the member or the individual to actually submit their application. So we're trying to utilize technology the best way we can to facilitate the process and the workflow. Now, this next one, if we're able to show it, is a maternal health demo. And it goes through and we find a need. We find, again, one of those non-medical needs that are there, and we go ahead and solve that need or set up an ability to solve that need using organizations like yours to help accomplish that and to get them to their appointment. So let's go ahead with that one if we have that one.
I'm calling to confirm Nicole's well baby visit on Saturday, November 15th at 11 a.m. at Charles County Regional Medical Center. Can you still make it to that appointment?
I really want Nicole to be able to get to that appointment. Unfortunately, I just really need my car that day for work, and I'm worried if I miss that shift, I won't be able to afford groceries. So just trying to figure out how to get Nicole to the appointment with Maria.
I understand. It sounds like getting to the appointment and affording groceries are both concerns right now. I want to help you with that. Since transportation is a barrier, let me see what I can do to help with that first. I want to help.
In this particular case, we would use Uber Health to get a ride to the doctor, to get this woman and her child a ride to the doctor and a ride home. But then ongoing in the journey, so if you can imagine, we're showing you snippets of what's happened with members that or individuals we've worked with, but it's not the end of the journey. Because I told you about that scheduling agent. Well, now we're going to schedule an appointment, the next appointment with the doctor. And once we know that information, if maybe it was already done and we understand what it is, or we set it up with them because the agent has the ability to do that, to set up the appointments for those individuals, either with three-way calls to the doctor's office, or if there's integration that exists with the health system, we can do those types of things with their practice management systems. And then there's a reminder set out. You don't just do it once and you're done. It's an ongoing relationship or an ongoing conversation to make sure and to ensure those things are happening. And even with organizations like yours, if there's a need for food, which this demo actually goes in, it's a little bit longer. There was a need for that because he mentioned if I don't go to work, then I'm not going to have money for food. And so there's a need for food that we'd actually refer to a local organization to help with. It could be a Meals on Wheels. It could be another organization. But then that, again, the glue that is Blooming Health is trying to tie it all together is calling the individual back or texting the individual potentially and saying, hey, did you receive that meal? Was that meal okay? Do you have other needs? And tries to figure out the continuation of that individual to understand what else is needed. Because once they get a need solved, a lot of times we're like, oh, we wipe our hands, we pat ourselves on the back, and we say, hey, we got that thing done. But there's a lot of other needs. But once to an individual, once you've gained the trust of delivering that food and getting that need filled, they may open up to a number of other needs, whether they be financial, whether they be loneliness that's happening in their lives that we can actually address and help. But always with the outcome or with the idea of facilitating an ultimate outcome in their journey of health, in healthcare. And so that's what Blooming Health is trying to accomplish, and we're doing it. We're kind of connecting those non-medical drivers with the actual medical outcomes that that the health system wants and that the individuals need. Again, removing barriers so they can't access care, helping them understand how to access care, what's the appropriate care to access, and then using community resources like yourselves and others to help remove the barriers that are preventing them from accomplishing it. Because if a person can't put food on the table, the last thing they're thinking about is that annual wellness visit that's coming up in a couple of weeks. They could care less about that clinical outcome, like their health plan cares about the clinical outcome, and their provider, the doctor, cares about that clinical outcome. We need to address their care in an integrated fashion, integrated delivery that includes those non-medical drivers. So let's go to that last slide that we have, which is about our security and testing. So a lot of people are tentative. If we talk about the 500-pound gorilla in the room, which is agentic AI, you hear a person calling on the phone. Now, keep in mind that person, that agent that we create for that workflow can make a phone call, but it can also text. It can email, depending on the preference of the individual to receive information. It can have a bi-directional conversation via text versus being on a phone with the individual. So there's a lot of capabilities that they have. But we do an extensive amount of persona-based testing with the agents. So like I said, it's not one big agent. There are a lot of micro agents that we test about gathering information. It has its purpose. It doesn't stray from its purpose. If it's asked a question that's outside of what needs to happen, if they say, I'm not feeling well, we're going to be transferring to somebody, to a human being to assess what's going on, right? We're not clinical in any way, our technology. We're not making decisions like that. But we constantly do, in all of our agents and our micro agents, that persona-based testing. We do automated quality and risk monitoring. The fun thing about AI is you can use AI to test AI. So you can create thousands of personas, AI personas that interact with the main agent, the workflow agent, to create thousands of regression tests over and over again to make sure that the agent's responding the way it should be. So it's very secure and a very secure deployment of agentic AI for the purpose of removing barriers to care and helping people gain access to the care they need. That's who Blooming Health is from a technology perspective, but we wanted you to know who we were, because we're bringing everybody together because we're all pieces of the puzzle. We're hopefully that glue that drives the person where they need to go, but not just simply drives them where they need to go, but brings the resource to them. So instead of saying, oh, you need a ride, here's the number to Uber Health, call the number. Self-service in the world of the underserved doesn't work all that well. They don't self-serve in a big way. And so what we're trying to do is to bring the resource to them, bring your capabilities to them, and then following up to make sure it's actually occurring and that they're satisfied with how it was delivered, and then making sure we understand if there's any other needs in the process. But it is very centered around the individual. And we aren't one, interoperability is always a big thing. I've been in healthcare a long time. Interoperability has been a word that's been used since I've been in healthcare for 30 years. And what I've realized in 30 years is I don't know if it's ever going to happen. I don't think there's going to be one system that everyone connects to that makes it all work. And so another big bonus of agentic AI is the ability to collect information and transfer information to where it needs to go. So instead of being completely integrated with everything, it's just a matter of sending data where it needs to go ultimately in the process, without having to be completely tightly integrated with everything in the community. So that's an explanation of who Blooming Health is. And I know that right now we have a little bit of time. I don't know how much time we have. 5 minutes for questions and answers. And Dr. Kavitha would be more than happy to answer any question you have for her. You know, we talked about Dr. Nima and Dr. Kavitha. No one says Dr. Phil, although there is a Dr. Phil, but I'm not it. But I can act like one, talk like one. Anyways, any questions? Anybody have a question for us? And that was clear, so clear. In the back.
disabilities. I'm curious as to what happens when somebody is answering the questions and it's just not going the way you want it to, or the way the person wants it to. Is there an option to say agent, or I want to speak to a live human?
So you want me to answer that, Kavitha? Would you like to answer it? The answer is yes. And one thing that is really good about the agents we're building and using is the conversation is driven by the individual. So it's not press 1, press 2. That's an older technology. And then, because we all know what we do when you hear that, right? Representative. Or you hit 0 on the phone as many times as you possibly can until it pumps you out to a human being. This is something that the conversation becomes much more of a, because people always say, well, what if it's not going the way we want it to? Well, the agent's going to go the way the individual drives the conversation, because that's their priority. If you're asking them a question about, well, what's your income? And they're like, I don't know how I'm going to put food on the table. Oh, we're so sorry to hear that. What's your income? It's not going to do that. It's going to say, let me help you with that. Because if we help them with what their needs are, we're ultimately going to get the information we want eventually. And with some, it may need to be that a human needs to interact to get all the information that's needed. That was a long answer to the yes. I could have just said yes. It can break out and go to a person.
Yeah, so I think in terms of the technology, how we are building it, we're building it in a way that it can enable that three-way calling and escalation to a human being real time. And we're doing this with specific care pathways or journeys in mind for patients. For example, in the case of an ED discharge, patient gets home, there's a discharge instruction they've been given. So the patient can receive the call and the agent walks them through the discharge instruction. But suddenly, if they say they're facing a symptom and they're not clear what they're going through and they want to talk to a nurse or a person, we can three-way dial in the nurse and let them talk to the individual live. And even the conversations the agent is having with the patient or the member is tracked. So when the nurse gets on the call, she can see what did the agent talk so far with the patient and can pick up from there. So everything is auditable. Everything is designed in a way it can be connected to a human being when needed. And we design the workflows for implementation of these agents upfront in that way. And also, one thing about the agents, as Phil said, is it's very natural conversations. However, it's also what we call as deterministic, which is more like it's a straight shooter, is a simpler way to say that, meaning it'll follow what you ask it to follow and doesn't try to go outside of that rails. So in this case, if we pre-design it to say, when the patient says X, trigger a phone call to the nurse, it'll do that. So it can also be predefined even before the patient asks for it in that way.
Hi, good afternoon. I'm Tawani Arujo with Texas Health Resources. In Texas, of course, we have a very large multicultural population and continuously growing. Large Latino population, folks from Middle East and Asia and India. So I'm wondering how much work you've done to address issues with accents or different languages and what the capabilities are there.
So there's a lot of progress made with AI and specifically within Blooming Health that we've worked on. So I mentioned 57 languages. So we do support 57 languages, but then there's dialects within each language. And I love this topic because I come from my mother was Cuban. I know Harker is not a Cuban name because my dad wasn't Cuban, but my mother was. So I grew up in a home speaking Spanish, and there are, for anybody that's out there that is Latino, I guess that is the politically correct way to say Latino right now. There's huge variations between whether you're talking with a Mexican, a Cuban, a Dominican, or somebody else. And with AI now, with our agents, it picks up on those types of dialects and can speak. It's not going to necessarily change its accent, but it can use terminology that's much more familiar to that individual. And so that again builds that trust and that ability for that person to be open. And it can recognize it from the get-go. So if we don't know the language they prefer, it's always going to go out in English. But if someone starts to speak Spanish and saying, I don't speak English, but they say it in Spanish, it will flip automatically and start speaking in Spanish with the individual or whatever language.
Or the other way around. I usually say poquito Spanish,
That's
and then it switches to English.
Yeah.
But I think to add to what Phil is saying, I think in terms of languages, it's very, very important to us in making sure it's culturally sensitive and easy to engage people regardless of what languages they speak. So that's been at the core of what we've been building since the beginning. And we often take feedback from native language speakers on, does this make sense to you? Does this resonate with you? And the advantages of the dialects is that, like, it can mirror the dialect that you're speaking, it can mirror the language you're speaking. And that's part of the engagement science, as Phil likes to call it, his favorite term, in thinking about how does that person want to be engaged, not just in the language and dialects, but also do they prefer the text or the voice? Also, would they prefer that we call them on a Saturday morning versus when they're in the middle of work trying to get things done on a Wednesday afternoon? So it goes to the date, the time, the language, the channel in which they want to be engaged, and how they want to receive that information that they actually find valuable for them. And we adapt all of this by learning and designing our solution in that way. As I said, we have 19 million engagements on our platform so far. So we use and analyze the data to think about what type of engagements drive actions and outcomes for that individual.
Right here, Dr. Elizabeth Bashir with East Texas A&M University. So my question was, do y'all adapt this to rural versus urban clients? Because we know some of the challenges, for example, with rural areas are pretty significant. Transportation, healthcare providers, closeness, what does that look like?
Yeah, in fact, 50% of the 6 million that I talked about live in rural areas. And we serve 50% of the members on our platform in rural areas. And what that means is for us, this is, again, we've designed our platform in a way that it's inclusive. So whether you live in urban or whether you live in rural area, you should be able to access. So what's the common denominator? When you think about rural areas, it's lack of broadband access. It's lack of internet or that digital divide that exists, which in turn limits the information and services they can access. Obviously, it's also resources, how long they're traveling, the distance to get access to resources, and capacity to serve them. So in terms of our platform, so that's number one, the fundamental piece to address the broadband access is you can reach people even if they don't have internet. And this can be done via landline voice calls. At minimum, if you have a landline phone in your home, we can reach you and the agent can still talk to you through that phone, which is a fundamental difference in how we deploy AI and agentic solutions versus other platforms, because you need to go on a website or you need to log into something to access it. Here, you don't have to do any of that. So that's another part. You don't have to sign in to something. And then the second piece is capacity and then also considering the other needs they may have. If they're living in a rural area, they might need transportation to get to any place that they need to get to. So connecting them to those transportation resources. And capacity of staff members at area agencies on aging in rural areas or CBOs in rural areas is very limited. So helping them recruit volunteers or helping them recruit other ways. So we think about it more holistically from a member and the service provider standpoint.
And I'll just add, I know there's another question. I'll add that, we don't look at agentic AI as a replacement. It's an extension of people, right? It's the ability to scale what you're already doing, but to scale it in a way where it can connect with hundreds, thousands of people to bring them into the mix to actually get accomplished. So it's not right now, if you're talking to health systems or health plans, they focus on the high acuity, high risk, top 10 to 20%. And the others don't get an experience because they just don't have the bandwidth to do it. And I think in a lot of cases, even in your own organizations, you're trying to reach people, and 3 and out is a term in football, but I think it's a term in community-based organizations as well. I tried 3 times. They haven't answered the phone. An agent never tires of trying to call. They can call forever. And it can text and call at the same time, text and say, hey, I'm going to be calling you. It can do a lot of things to try to get that member or that individual engaged. So.
Great, thank you. We also have a question from Zoom. Where is the data that the agent is given resourced from?
That's a great question. So we work with health systems and health plans predominantly to help them with a number of different workflows, right? Post-discharge, Kavitha talked about. Maternal health is another one. Primary care could be another one. There's always an outcome they're looking for or desiring. And obviously we engage the community when we need to remove barriers that they have, because we screen for those types of things in that process. It could be simply a screening process, health system. So that information we get, all the information on the individuals, their phone numbers, even sometimes their race, ethnicity, and language data, if they have it, all that type of information we ingest so we understand when we outreach, how to outreach and how to engage. But that's where it's sourced.
Yeah, and I think to clarify, we are a HIPAA compliant organization, right? Like any data we collect or source is being specifically used to enable that communication and in a minimal way that's required to deliver that communication. But also on the sources, to Phil's point, the beauty of this is also that we are trying to connect medical and non-medical, right? So collecting information and the patient. So we get sourced the information from the patient, asking them on their needs, on what they prefer, and whether they actually achieved the outcome, which is you were food insecure and you didn't have access to fresh groceries. Did you actually resolve it? Did you actually feel secure in terms of nutrition and food? And then also talking to the CBOs. And because our platform is implemented in their day-to-day operations, I'm glad to see Mark here from Dallas County. And they've been using our platform to send reminders about their senior center programs or alerts when the operations need to be disrupted or a center needs to be shut down. So we gather those information from the CBOs, from the healthcare, and from the patients, and we try to coordinate the care digitally as well to getting the information to the right people across these aisles. So that's another piece that I wanted to add. All right. I think this was a great session. Thank you so much for all the questions. I want to quickly have a call to action for you. Next slide, please. So I have two asks. I told you why I'm here in Dallas is to meet you all, connect with you all, but I also have two specific asks. We want to grow here in Texas. We want to work with more partners. So if you are a community-based organization, a health system, or a health plan that's thinking about integrating medical care and non-medical care, we want to talk to you. We want to at least understand the problems you're facing and how we can support you in that journey, especially with the Medicaid coverage cliff coming up. We want to really support the organizations in ensuring more people stay covered. And so go to this QR code, scan it, and let us know if you want to continue the conversations with us. Second, and most important, is I appreciated all the questions in the room, but I imagine there's a lot going on in your head on how you think about the solution and any suggestions or feedback you have on the product itself. And based on your valuable experiences on the ground, how you see this working, not working, anything that resonated with you, did not resonate with you, give it to us straight. We can take it. So put us any of your feedback in the forum, and would love to, again, continue to take feedback as we end the day as well today. So thank you so much for your time.